Next speaker is Dr. ASHRAYA NAYAKA, Senior Consultant Vitro Retina Services and Uvea at the Eye Foundation Group of Hospitals, who has a dynamism, charm, and uniqueness of his own. And he is going to be talking on drill, BRP, and CMD. On to you.
Thank you, ma'am. Thank you, Srinivas sir, for the opportunity. So, let's dive in. So this is the real world diabetic macular edema, where we see ellipsoid zone disruption, a large cystoid space, which progresses on to be a cystoid macular degeneration or a hyperreflective wall later on, or there are broken septae, which are called as bridging retinal process, or the hard exudates, and of course the topic drill, that is disorganization of retinal inner layers. So coming to the drill, it is defined as inability to segment the boundaries of the inner nuclear layer, outer flexiform layer, and the ganglion cell layer and inner flexiform layer complex on OCT. Central 1000 microns to 3000 microns have been used by different studies as the area of interest. An additional parameter which has been very important is the foveal drill, which is the inability to distinguish boundaries between any of these inner retinal layers in more than 50% of the foveal 1 mm zone. So the Sun et al. Showed that described the mechanical pathogenesis of the drills due to macular edema that causes the stretching of neuronal cells. The Nicholson et al. Proposed an ischemic process describing a significant association between the presence of drills and the macular non-perfusion, which was evaluated on fluorescein angiography. This paper by Sanamo et al. Published this year showed the pathology as described by Nicholson et al. To be ischemic in nature. So you can see the on OCTA, there is reduction in vessel density in superficial capillary plexus and deep capillary plexus, and a greater FAZ area in patients with drill in comparison to patients with no drill and normal OCTs. So there are after the Sun et al. Described about drill in 2014, quantification of drill was done differently by different authors, but this quantification by Grewal et al. Is very robust and repeatable. So what they did was they took one foveal scan and 3 above and 3 below at an interval of 238 microns. So they recorded serially on these 7 scans at every visit, and horizontal extent of the drill was measured in microns, and the vertical extent of the drill was defined as number of scans out of 7, with the drill calculated as a percentage. So this is a quite easy and well-defined method of quantifying drill. So coming to typical case, which would looks like this, with non-proliferative diabetic retinopathy with macular edema. You can see this cystoid macular edema with the parafoveal lipids. But on OCT, you can see there will be inability to distinguish all the 3 inner layers, and we can say that there is a drill. So in another case, they can be associated with parafoveal lipids and sometimes hard exudate plaque. And you can see this drill, and so I have subjectively measured it to be around 1732. So this variability in inter-observer thing has made it difficult for all the studies to have a correct dimension, because it can vary from OCT to OCT, from observer to observer, and the OCT apparatus to other apparatus. So drill drill, interestingly, is not a fixed biomarker, and changes in drill over time have demonstrated prognostic value. And in drill, as described by Sun et al., evaluating patients with DME, an increase of drill by 300 microns correlated to 1-line vision decline at 8 months, and conversely, a decrease in drill by 250 microns correlated to one-line drill improvement in vision at 4 months. So this was a case of a 54-year-old diabetic patient was treated for chronic edema, had taken multiple injections and presented to us with vision of 624. And at that point of time, we gave 2 accentrics, but there was not much difference. Then we switched to Ozurdex, and that is when we started to notice some resolution in drill. And so even though the edema has increased previously, but the drill had started to disappear, and that is when we noticed a small increase in vision. So then we gave the second Ozurdex, and the patient didn't improve with the vision, but edema subsided, but continued to have not more than vision of 6/18. And at various sections, it can vary from within the same OCT, it can be 1242 to 1298 microns. So this is a limitation of the drill. So drill again was described in diabetic retinopathy also, and the Joltikov et al. Studied patients in diabetic retinopathy and showed reduced retinal function is associated with reduced retinal thickness. And Onishi et al. Showed that regions of the retina with drill demonstrated significant perfusion deficits compared with adjacent control areas without drill. So and drill can also be seen in other entities like branched retinal vein occlusion. And Babievich et al. Demonstrated prognostic potential of baseline drill and drill burden throughout the treatment of visual acuity for patients with treatment-naive branch retinal vein occlusion and central or hemispheric vein occlusion. So this is another paper by Balaratnasingam et al., who demonstrated that there is enlarged FAZ and drill can be correlated and can be correlated well with the visual acuity also. So
1 minute remaining, sir.
So this is another case where the patient had a macular vein occlusion and ERM as well. So clinical implication is for each 100 micron increase in drill, there is a negative impact of approximate 6 letters, which is more than 1 line on ATDRS chart. And the paradoxical visual acuity changes, even with worsening visual acuity and resolving DME, patients with drill is usually more than 500 microns. And there can be worse visual acuity even with DME resolution. Conversely, there can be good vision despite having concurrent edema, which I showed in that case. So this is a case bridging retinal processes as described by Farhan et al. Are basically remnants of Muller cells and bipolar cells, and it can these usually resolve with good vision when treated, and usually can also be not associated with drill. And when these when these bridging processes break and become large, they are known to described as cystoid macular degeneration. With the dimensions have to be more than 450 microns horizontally and 300 microns vertically. So this is a case where there was no association with the drill. We always feel CMD is associated with drill. It can be independent of drill also. So this is a case where we treated the patient with Ozurdex. Patient had resolution of cystoid macular degeneration, but vision did not improve. So again, these are they don't really have visual acuity improvement. So drill, bridging retinal processes and cystoid macular degeneration are can coexist because they are part of the same pathological process. And depending on which section we take this thing, you can see a cystoid degeneration, bridging retinal process, and you can also see some drill here. So quantification has always been a limitation. And since there is no histopathological correlation, we really don't know what is the underlying pathogenesis. And very few small-scale studies have showed the relationship between drill and visual acuity. So with newer OCT platforms, it is automated, and the quantification of drill can be automated, and it can be used as a useful tool. And with any upcoming histopathological studies can really throw insights in how the pathogenesis of drill might be. And my take-home message would be, with the better resolution and more number of B scans being added to the OCT apparatus, it can be easily be identified with less ambiguity. And drill excellently correlates with severity and chronicity. And all these things are part of the same mechanism. And with new improved automated segmentation and AI, more than ever, this can be of more use in the coming days. Thank you.
Dr. ASHRAYA, that was a wonderful talk, quite complex. But does it mean that its use is limited in clinical decision taking because it's sort of a late clinical marker and has less predictive value?
Ma'am, the problem is as I told you, the quantification is very difficult in these cases, because what is the extent of drill and how much when to treat and when not to treat, only we'll get to know at the end stage. So early detection in early cases, they do resolve, and actually drill can be reversed also. So we have seen that it reverses if it is treated early. So early identification is the key. So we need better resolution scans like swept source, and all those things can give us a lot of insight into how this occurs.
Dr. Srinivas?
Yes, madam. Do we have Girdhar sir also, expert panel? Girdhar sir, are you there?
I didn't see him.
Okay. I think we have Unni sir and Dr. Anand Rajendran here.
I am here. I am very much here.
Okay, okay. Sir.
I went out for a short nap. Tell me.
Okay. So
Yes,
I think ASHRAYA nicely explained about the drill, sir.
Yeah,
About
I have one question to ask.
Yeah.
Is there any study on OCTA in eyes with drill?
Yes, sir. It has been published in this January 2021.
Yes.
So by Sanamo et al. So they have studied the correlation between the vessel density at superficial capillary plexus, deep capillary plexus, and the foveal avascular zone enlargement. So they have in the paper they have talked about that there is statistically significant difference between patients with drill and no drill. So the vessel density is what they have talked about.
Okay, thank you. Quick question to Dr. Unni and Dr. Anand sir. He has spoken most of the points regarding the disruption of the impulse, association with macular ischemia, good counseling tool. And he also mentioned about the reversibility of the drill and its association with the therapy, especially in the resistant and non-responsive cases. So I want to know your opinion about this on the reversibility of the drill and which agent to choose. And second question is to ASHRAYA. How will you differentiate between the wall of these cysts versus the BRPs, bridging retinal processes?
So, sir, that is the caveat. So that's what I showed that last image. So depending on what section you take, we call it as BRP or it is a cystoid degeneration. So
it's not that clear.
Hello.
Yeah.
Sir,
you're audible.
Sir, that is the caveat. That's why after it was described in 2014 because at what section you take the scan, whether it the same thing can be bridging retinal processes or in another angle, it can look like a cystoid macular degeneration. It is very difficult to distinguish between these two on a certain scan. But at one section, you can call it as remnants of these Muller cells and bipolar cells and call them as BRPs.
Yes, Anand sir. And
yeah, so I think drill is important. I never used to pay as much attention earlier as I do now in the last couple of years. I think there are, two or three real studies which I think some of them you quoted. The one by Jennifer Sun, the one by Usha Chakrabarti's group, I think Radha Das et al. So these are two keen ones, and one interesting one by Dr. Radwan et al. So drill is useful because it actually predates and correlates better with visual acuity than diabetic macular edema itself. And it also is better correlated with non-diabetic macular edema. I think you mentioned that very briefly, is that you see drill in not only diabetic macular edema, you see it in RBO macular edema also, RBO edema. So the correlation of drill with the resolution of edema and the acuity is better actually with non-DME macular edema than DME macular edema. And it also correlates better with visual acuity improvement trends than the macular edema itself. So therein lies the significance of drill, and that is why I don't think you should only look at it in late changes. When you see drill happening early, that should be a portender of trends. Now, also, I think you briefly mentioned that from the Radwan study we learned, but something very beautiful they showed us, that when you look at 4 time points. I think they looked at it over 4 months or 6 months or something, 4 time points. They classified them into early resolvers, late resolvers, then persistent, and those that don't resolve at all. In cases where diabetic macular edema improved. And they found that beautiful correlation was seen in visual acuity in cases which resolved early as well as those which resolved late. And it was a beautiful S-shaped continuum if you look at that graph. So there is a definite gain to be had from a trend point. Visual trend improvement point, you can portend, you can predict how a patient is going to improve by looking at how that drill is improving over time with your anti-VEGF treatment, even if the macular edema doesn't seem to be improving. So I think that's a beautiful thing which that Radwan study showed us, that in patients who improve early, within the first 2 months, when the drill goes away, macular edema may be coming down a little, those patients will end up with better acuity 6 months down the line. So that's a very strong thing, if you do see a drill. So when you see that drill, do latch on to that, identify it, look at how it's trending over time with the anti-VEGF. That will give you something to talk about.
I agree.